I'm going to be talking about OCT, use of OCT in diabetic retinopathy. Excellent. So, well, as you've heard, I mean, really, OCT has transformed the way we assess anything in medical retina. At least in our clinic, we don't really look at the patient a lot anymore. We look at the OCT, is the reality of it. So I'm going to be talking about, conflicts. I have done some research with Optos, so wide field imaging. Bayer helps fund access to an OCTA, so I'm mostly presenting images from Spectralis system, but I've also used the Topcon and had some funding from Novartis as well. I'm going to be showing aspects of interpreting OCT in diabetic retinopathy, the potential uses of OCTA for assessing the health of the macula and new vessels, and also interacting a bit of that with wide field imaging. So I'll finish off with a new camera called the Monaco, which is from Optos, which combines wide field color and OCT. And we've known for quite a long time, essentially, that the OCT is more sensitive than the clinician. I certainly remember when OCT first came out for diabetic retinopathy, there was debate about, well, did you need to do that? Certainly one of my older colleagues, even today, is still reluctant to request an OCT in diabetics because he said, well, the diagnosis is clinically significant macular edema. That is a clinical decision. It's not a photographic decision. So if I'm going to treat them with laser, I want to see that swelling with my, my lens on the camera, on the slit lamp. But the reality is that the OCT is much more sensitive. Everybody's eyes are a bit different. We're better or worse at using our lenses. We may or may not see the fluid. The OCT is far more sensitive. And there have been many studies showing that. So really, that is the gold standard of telling you, is there or is there not swelling? So if we do an OCT, this is a spectralis showing you a small cyst in the more inner part of the retina. A patient like this may have pretty good vision. This particular patient has actually got an amblyopic right eye. So this is 58 letters on the EDTRS score. Their other eye is 66. So I think they probably left their glasses at home, which is often the way. They've got a little bit of fluid. Are we going to treat that or not? This is center involving, so I'm not going to laser that. So my options are to inject the patient or wait and see. And in this particular case, I opted to wait and see. 4 months later with no treatment, hasn't really changed. It's just not very swollen. It's a bit swollen. It is central. Am I really going to inject them? At a year, with no treatment, it actually just resolved, and I didn't treat them at all. So the OCT is very good at finding a problem, but it doesn't necessarily mean you need to intervene. Diabetics, they often get a little bit of swelling, and they may or may not need treatment. And your options for treatment, as I said, are laser or injections, both of which are not without their risk. On the other hand, they both work very well. So this is an example of where we did use focal laser. So I'm just going to show the series of what happens with the OCT over time. This is back in 2017 in January, 73-year-old man, type 2 diabetic, 6/9 vision, so slightly reduced. He's got, there's not really any thickening there. You can, oh, hang on. Which is, oh, there. He's got a little bit of exudate, you can see here. Maybe slightly swelling, but really the foveal profile is pretty normal, so we don't necessarily need to intervene at that point. This is a couple of months later. There is beginning to be a bit of edema, but you have to remember this is a very high-resolution scan, so essentially the vision's unaffected, and this is not actually very swollen. But a little bit later, it's a bit more. It's still just off the center, so we felt it was safe to laser rather than inject. You can see on the infrared image where the swelling is, and the fovea is just there, so we did some focal laser. And focal laser does work very well. So this is a couple of months after the focal laser. The fluid is gone. You can see these little marks, the little white dots at the level of the RPE. That is the damage we've done with our laser. You can see brighter signal where it's clumping a bit of pigment together. Because you remember that as Theo said, that the OCT is image is all generated from reflected light. So if you get a brighter signal, you've got a darker bit of pigment, something that's reflecting the light. And you get a shadow from where that is. So there's pigment there, and that's causing a shadow. And that's a consequence of the laser. And then we follow it through, the fluid's resolved, but you can see where these little pigment marks are, and they do leave little holes in the RPE. And if we look at the color image, you can see what's happened. There's the exudate. The exudate is resolved, but we can see our laser scars. So laser works very well. The OCT is a very good way of monitoring the effect, but it does cause some damage. So we always have this debate, do we really laser them, or do we wait until it's more involved in the center and then we do injections? Because injections isn't going to leave any scarring. On the other hand, you keep having to inject them. Do we always need to treat? As I showed you that first example, where the fluid went away. The other thing is, how do you look at the OCT? You look at it cross-section. I've just shown you cross-sections largely so far, but you also have the topographical map. So this is a map, and the red is thickness, the white is even thicker. And there's obvious areas of thickening around here. The fovea itself is okay. The question is, is this something I'm going to treat? Is that actually due to edema or not? So you have to be a little bit careful, because if you look at the cross-section on here, that patch, which was swollen here, is actually not edema. It's swelling in the inner retina here, and it's actually due to a cotton wool spot. It's an infarct of the circulation there. And if we look on the color, it may not be that clear, but there's a cotton wool spot, a little floater there, another cotton wool spot. So actually the red patches on this particular patient, the swelling, is not due to edema that you need to laser. It's due to a cotton wool spot causing secondary swelling due to the ischemia of that area. So you don't want to laser that, and that will settle down as the cotton wool spot resolves. So you have to look at your map, but you do have to look at your cross-section to interpret what the swelling really is. As you well know, we've got three sort of treatments, anti-VEGF treatments for diabetic macular edema. That's Avastin, which is not licensed, ranibizumab, and aflibercept. In the UK, currently we're using ranibizumab or aflibercept, and they're licensed for diabetic macular edema, but we have restriction of they're meant to be more than 400 micrometers. So for us, we have to decide, well, is it more than 400 micrometers involving the center before we're actually going to treat them? The benefit of all this did come from a number of clinical trials, as you know. And it's always important to know what actually happened in the trials. This is an example from one of the trials of the effect of ranibizumab on macular edema, showing you the OCTs. And the first thing to notice is it does work, the fluid is going away, but the second thing is to notice it doesn't go away immediately. So you do your first injection, you bring them back, and you think, oh, it didn't really do very much. That doesn't mean you should give up and do something else or give them steroids straight away. Just keep injecting them and the fluid will go down. It varies, but it can gradually work. And that's why in the clinical trials, often they're giving 7 or even 9 injections in the first year. The license now for aflibercept is give them 6 injections, or is it 5? 5 or 6 monthly to start with in diabetics. So you give them quite a lot. And then hopefully you need to use much less as time goes by. And you can see the benefit. This is a sham arm. Sorry, that was the sham arm of the trial. Ooh, sneak preview, showing the edema just getting worse over time. So the injections definitely work, but remember it takes time to work, and you have to do quite a lot of treatment if you want to get a full benefit. So one of the issues for us is it more than 400 or not? And you think that would be pretty straightforward. It normally is, but again, you've got to be careful with OCTs, because you're relying on the map and you're relying on the segmentation, which can always go wrong. So this patient clearly does have edema. There's a lot of swelling in the middle here, but the measurement in the center tells me it's only 300 and something. Sorry, I can't see it on the screen. Anyway, it's less than 400, but you can see the segmentation line has gone wrong. The patient blinked, so there's an artifact in the middle. So if you're purely looking at the number, you'd miss the fact there was swelling and it's more than 400. So you need to look at the whole picture. Another example, this certainly looks like central swelling of more than 400 that we should treat. We looked at the map, and you thought, oh, that looks like it's off-center. I could probably laser that. But be careful of that if you're just going to use the map. Remember, don't forget, probably do look in the eye sometimes, because if you just look at the map and laser them, you might well have a bit of disaster. So you've got to know where the patient is fixating. Actually, if you look at that OCT scan, it's not lined up properly. This is the ring that the photographer's set. It's going above the superior arcade. So what happens, certainly on the Heidelberg system, is they do an image, and then you follow them up, and they always set that reference to the same point every time. So they come in and they get exactly the same point, which is great. But if set the reference wrong in the first place, every subsequent image will also be wrong. So you have to look at it and maybe reset it. Because of this patient, actually, the center, if you look at that picture, is right in the middle here. So you can move that target, and you can move the whole grid. So if we do that, actually, this is 440. If you look at that number, that is the center of the fovea when you look at the patient and check whether they're actually fixating and what the thickness is. So you definitely don't want to laser that. You want to inject them. And if you did laser them, it'd be a bit of a disaster. So be careful. And then you reset it, and then hopefully your future images will be correct. Oh, is it always macular edema? Of course, you get people with dual pathology. So this patient is diabetic, but they've also got an epiretinal membrane. And you can tell that because there's a wrinkling on the surface here. And we're seeing the posterior hyaloid up there, and there seems to be cystic fluid. So is this fluid with an epiretinal membrane that we need to inject? Well, you need to look at all the scans. Think, oh, is there sort of a partial hole or an outer retinal hole here? Am I just going to inject this anyway? Well, no. This is another thing. This is done on the fast scan on the Heidelberg, and it'll vary at whatever camera you've got, what the scanning protocol is. So we've done our standard scan. We missed, just by looking at the scan, we missed the fact that actually there is a full thickness hole. When we put it in a higher resolution and did a proper scan right through the middle, there is a hole, which we missed on our normal scan. So we don't want to be injecting this patient at all, and they need vitreoretinal surgery or something. And we're going to have a talk on that a bit later on. Another example of is it thick or isn't it? This certainly looks thick. There's a lot of swelling all across down the red. This patient's more complicated because they have macular degeneration and diabetic retinopathy. They've got drusen, they've got a thickened RPE, they've got interretinal swelling. How much is that? And the way it measures the thickness is from below the RPE here. So you can see the red line, and then you see the top. So it's coming out with a measure of 440, but actually some of this is the AMD. And it's not actually, there isn't that much edema. So again, do we need to inject them or don't we? Is this actually diabetic retinopathy or is this AMD? I guess you could argue, well, it doesn't really matter. We inject everything. So to some extent, the minutiae of all this, as long as it's a leaking edema, then you probably won't go that wrong with an injection, to be honest. But if you wanted to be sure about it, and it does probably change certainly the prognosis of how many injections you're going to be giving, you're much more likely to keep injecting an AMD patient than a diabetic. So looking at this, the fluid is in the inner retina pit, these cysts, that looks like diabetic retinopathy. So anything that's a vascular problem, diabetic or vein occlusions will cause fluid in that sort of layer, as opposed to AMD, which will often be associated with subretinal fluid. And if the clinical scenario, this patient, don't forget, we're focusing on imaging here, but actually you need to put it all together. This patient's vision's perfectly normal. He's got 6/6 vision, 85 letters. There are drusen and there are hemorrhages. So we don't necessarily need to treat them at all. We do need to follow them up. But if you go back to that image, there's just a little bit of fluid here, in fact. So if we ignore the thickness, because it's confused by AMD, there's a little bit of thickness, but the vision's normal. So I'm not going to treat them at this point, but I am going to follow them up. There's been a lot of discussion about what features on the OCT predict outcome or may explain why the vision is not as good as you might hope in a diabetic. And you get all these different terms that you may be familiar with, or may not, such as disruption of the ellipsoid zone, DRIL, which stands for disorganization of the retinal inner layers, hyperreflective foci, increased size of the foveolar vascular zone, or interretinal cysts. All of these were shown to be associated with worse vision in a study looking at vision in diabetic and vein occlusions. And then another study in which Ozurdex was the main treatment said if there was some subretinal fluid or absence of hyperreflective foci, and the integrity of the IOS-OS layer was okay, you were more likely to have better vision. So you can look at your OCT cross-section in great detail and try and give some idea of whether the vision's going to be better or worse. And there's a lot written about it. How really useful is that? Well, I think that's where you don't want to get too worried about all this. I mean, it's interesting, but is it really going to stop you treating them or not treating them? There's a good paper here by Susan Bresler looking at the drcr.net data, where they looked at 37 different features to try and associate whether you had a good or bad outcome of 1 year of giving ranibizumab. And adjusting for all that, the things that meant you're more likely to have a better vision was just younger age, less severe diabetic retinopathy, no epiretinal membrane, and a sort of faster resolution of your fluid. But the main thing was, in fact, pretty much everybody did well with your injections. You know, they only had 11 people who lost some vision, and only 6 people got any worse fluid. So regardless of whatever you had drill or any of those things, you're going to do better with your injections than not. So you can worry about whether there is or isn't some drill or some ellipsoid zone layer, and it may give you a slightly worse prognosis, but it doesn't mean you shouldn't treat them, because they're probably going to do well, or at least not get any worse. And this is an example. I mean, you'd think, well, you know, and then the reality is, what are you going to do? Are you not going to treat them because their OCT looks horrible? You might tell them, I'm not sure how good your outcome's going to be, but it doesn't mean you're not going to treat them. I mean, this patient was somebody I saw, and this is 5 years ago now. Terrible vision, 360 in both eyes, horrible edema, 600. You know, maybe there is some surface wrinkling retinopathy. There's certainly drill, if disorganization, the retinal inner layers, the whole thing looks awful, doesn't it? The fluorescein looks even worse. This is the fluorescein of this patient. They've got dyspnea vessels, they've got vitreous hemorrhage, they've got extensive ischemia in the left eye and in the right eye. Horrible ischemia leak, really looks awful. We gave them a ranibizumab injection, 1 injection, 6/18 both eyes, and the macula's flat. You know, it's really good. And that is dramatic. You're not going to get that with your laser. And that controls the new vessels too. That isn't obviously the end of the story with this patient. They've now been followed up, and I've seen them again just a couple of months ago. Their vision's about the same. They never got perfect vision, but they up to 6/15, 6/18 after 5 years. They've had laser in both eyes. They've had 14 injections, 14 or 15 anti-VEGF and 3 Ozurdex. So they're continuing to have treatment, but this is 5 years of what looked like a hopeless case with an awful-looking OCT, and actually they're doing quite well, really, all things considered. Prior to that, they would have gone blind. Well, they were effectively registrable blind at the beginning of this. So it is, you can look at the details of the OCT. You do need to know what the diagnosis is, but I think you don't want to not treat somebody based on that. Just a sidetrack about whether your fluorescein helps you with, if it's a lot of peripheral ischemia, is that treating the peripheral ischemia, will that reduce the number of injections you need for central involving edema? So if you've got edema in the center and you've got peripheral ischemia, there's a suggestion that if you do peripheral laser, you reduce your ischemic drive and you may need less injections. And that should work, but reality is it doesn't. There's 2 studies, one of which I've been involved in, the RDP study, where we randomized people who did exactly have that, peripheral ischemia and macular edema. We randomized them to PRP and we gave them injections and followed them for a year, and it basically didn't make any difference whether you gave them the laser. The number of injections was the same, the vision outcomes the same. The DAVE study is done in America, similar thing, but they followed them for 3 years, and they did much more laser. They repeated the laser if they didn't think they'd treated all the ischemic area, and they gave them injections for the central edema. Same thing. They couldn't show a benefit of doing the laser in terms of number of injections or visual outcome. Indeed, possibly you got slightly worse outcome by doing the laser. So it's disappointing. You can't get away from doing your injections for central edema. So going into OCTA, how useful is that really in diabetics? You know, it's great pictures. Is it really going to change what you're going to do? So I want to particularly look at it in regards to macular ischemia, and then also some we're starting to look at new vessels and ERMA and what can we learn about it with that. This is an example again of a horribly ischemic eye. On the Ophthalmica fluorescein, you can see they've had some PRP, although maybe it's a bit scattered, but there's almost no circulation going temporally from there. You can see some residual capillaries, still got pretty active new vessels. This is the fluorescein, and you can see them leaking. The OCTA, we can also see that the foveolar vascular zone is very enlarged. We can see areas of capillary dropout in quite a lot of detail. And if we go a bit more temporally, we see that ischemic area, and we can see the new vessels. And on the Heidelberg system, you get a yellow where the flow is, and you can see these vessels just in front of the retina. So we can see similar thing, although a much smaller scale than you get on the fluorescein. We also don't see the leak. But we can certainly explain why the vision's very bad on this particular extreme example. But what about, more commonly, that is clearly a very ischemic eye. So you're not really in any doubt the vision's bad because it's ischemic. The more common scenarios where the vision's a bit down, is it really down because of macular ischemia, or is it down because they're not properly refracted? Or, what is this? Will the OCTA help you tell you what the vision should be? And that gets much harder. And that's the same issue to do with the drill and the ellipsoid zone loss and all these things. When you get to the nitty-gritty of an individual patient, will your imaging tell you what the vision should or shouldn't be? So this is an example of the thickness is about the same. Maybe there's a slight cyst on this left eye compared to the right. 333, 321. But the vision is different. Oh. 6.9 in the right, 6.24 in the left. So why is that? When you're looking at the cross-section of the OCT, they look very similar. Possibly the left one's slightly worse. Is that really enough to make the vision that different? We look at the OCTA, and on OCTA you get different layers. So most of the machines separate it into superficial venous plexus and deep venous plexus. So we've got the superficial and the deep. 6.9 eye, 6.24 eye. Is that different enough to explain the vision? There is some difference. So when you start looking at it, you start thinking, well, that deep venous plexus is worse than that one, so maybe it does. But it's not that certain, is it? What about on this case? This is a 36-year-old patient, 6.9 vision, so fairly good vision, but not perfect. The thickness of 408. They have a superficial venous plexus foveolar vascular zone area of quite small. This is another patient, but this time they've got 6.6 vision. They do have some loss of the ellipsoid zone. They do have this drill. And they've got a larger foveolar vascular zone. So I guess my point is that it didn't help me, did it? This person's vision's better, but they've got worse signs. So for this individual, it's much harder to be sure what these measures really mean. This is another example, and this is again to do with artifacts. You have to be careful when interpreting any image that it is what you think it is. So this is a superficial venous plexus. This is the deep venous plexus. So you look at that and you say, oh, this is a bit ischemic, and you read papers that saying the deep venous plexus could be worse. And that's more often associated with ischemic diabetic retinopathy and would explain reduced vision. But look carefully. This is based on the automatic segmentation of the scan. So you see the red lines. There's some cystic fluid here. So these patches are probably not ischemia at all. There's no vessels there because there's a cystic space there. You've missed it based on this distribution of the automatic segmentation. So you probably need to you do, in this case, need to manually move these lines a little bit to detect where the vessels actually are. So this isn't really ischemia, or maybe partly ischemia, but it's partly just space. So the other picture you can look at is that. That black is where the cyst is. So that black is actually just fluid and not loss of vessels necessarily. So we've done a study trying to look in more detail about this, about can we predict the vision using the OCTA and these other measures. 57 eyes of 37 patients, mean age of 55, majority phakic. Some of them had previous treatment, but most of them we'd got rid of the macular edema, because I think if you've got too much macular edema, it's pretty hard to do any of these measures very accurately. And we were trying to correlate the size of the FAS with the visual acuity. You can try and grade your FAS shape based on the EDTRS grading. So there's a protocol for measuring diabetic macular ischemia based on looking at the ring of the foveal vascular zone to do whether it looks completely healthy or a bit mottled, a bit broken up, or whether you've lost more than half of it, or sorry, more than half, or completely destroyed. So you can get a crude grading of, that is one way of grading the degree of ischemia. If you do that, we looked at the EDTRS grade, so that macular grading, with the size of the deep foveal vascular zone. And you do get a trend. But actually, there's quite wide confidence intervals here. So between normal and severe, there's definitely you can definitely tell. All the stages in between, much harder to tell. And same if we look at the ischemia grade. Sorry. We've also looked at the regression model looking at the visual acuity with this size, and there is a trend. But you can see some people with all these different ranges of vision will have the same deep foveal vascular zone area. So I think for a study of a group of patients, these measures are probably very useful. You can get a trend of size of the foveal vascular zone, and you can correlate that with vision. But for an individual patient, it's much harder. And partly we know that anyway, because in healthy people, they have different size foveal vascular zones. Male and females have different size foveal vascular zones. It changes as you get older, even with completely normal vision. And you can have a large foveal vascular zone or a small one and completely normal vision. So the starting point is very different for each person. So with diabetic ischemia, I think it's really quite hard to tell. There's lots of other measures you can do on these OCTAs to do with the circularity index, the density of vessels. There's all sorts of measures. But as far as I can tell, reading all this, it's good for a group of patients, and it's probably very good for the individual following over time. So I think it'd be much more useful to use it as a follow-up tool. So you do a picture, and then a few months later you do another one, and you may be able to tell the change in ischemia. But it's quite hard on an individual picture to predict much. What about in new vessels? So this is the Ophthalmica picture showing an area of sort of fairly fibrosed new vessels up on the superior arcade here. They show up really well with the OCTA. So you can see the network of vessels. So remember, this is no dye. This is just an OCT, but it produces great pictures. On the Heidelberg system, currently it's quite a small field of view. There are other cameras, such as the Zeiss Elite system, the swept source version that can do wider field OCTA, but the technology is changing all the time. But you certainly get a pretty high resolution picture. You can then also, and I think it's very important though, to compare your en-face image, your flat image, with the cross section, because this is in front of the retina. You can see it draped flat across the top there. Why is that important? Well, why do we want to know about these new vessels? If there's new vessels, we're going to laser them. But do we need to laser them? What is the risk of these vessels bleeding? Because if you go back to your EDTRS studies and the early studies of the benefit of laser, it's all to do with reducing the risk of blindness. And small new vessels elsewhere, you don't necessarily need to treat them at all. Small dyspnea vessels, you don't necessarily need to treat unless they become high risk and there's associated with hemorrhage. There's various features that you can decide something's high risk or low risk. But one of the risks clearly is there traction on these vessels? And so how do we best look at that? So this is a patient who's clearly had only a partial PRP for new vessels. It's really hard to see, but there is a little bit of new vessel here, which is actually showing up on our Optos OCT that we happen to do with the macula, but on the infrared, there's a little bit of new vessel there. On the OCTA, we can really see that detail very well. There's the new vessels here. But on the cross-section, you can see the flow in there. That's the yellow showing the flow. So this is combining the structural OCT with the flow map, which is the yellow, and it's the flow which produces that image. This is the structural OCT, just from the reflected light. But essentially, these new vessels come forward. They're attached to the posterior hyaloid. So even though they're a tiny little bit, they are at risk of bleeding because they're still attached to the vitreous, and they could bleed if that vitreous changes. So this patient does need more treatment, even though it's a very small bit of NVE somewhere else. And what about these images? So this gets quite interesting, really, because the definition of new vessels is normally said to be, or in the trials, it's been based on stereoscopic color images that you can see that the new vessels are coming forward and that they leak on a fluorescein. Whereas the definition of IRMA, intraretinal microvascular abnormalities, as the term implies, is interretinal, so it doesn't come forward and it doesn't leak on a fluorescein. So what do we see on OCTA? Is that really true? We zoom in on here with our OCTA, and we can see a whole lot of things. We can see a loop of what probably are new vessels, and we see various other bright spots. If we look at the cross-section structure of that central bit, well, that is a new vessel by the definition of coming forward through the internal limiting membrane, and it did leak on the fluorescein. But this tiny little dot up here is also a little new vessel with flow in it that certainly would have missed otherwise. This little patch down here is not coming through the internal limiting membrane. It's causing a slight bulge on the internal limiting membrane. So it's an IRMA, but it looks like it's probably a new vessel IRMA. It's an IRMA anyway. And there's another patch that looks very similar on the OCTA that's also interretinal. And did they leak on the fluorescein? Well, 3 of them do, including this one, which is interretinal, and that one didn't leak. So there seems to be a slight disconnect between what leaks and what doesn't. I think you can get interretinal new vessels which do leak, and you can get interretinal new vessels that don't leak. And another example, this is a patient had some PRP, they've still got some leaky spots. That looks like a new vessel, it's leaking. We do our OCTA, but interestingly over here, there is a new vessel in front of the retina that has got flow that doesn't leak on the fluorescein. We missed it on our fluorescein. There's a larger patch, which is obviously there. So we're finding quite interesting things about how we're defining new vessels. And I still think in terms of are you going to treat it or not, it should be one that's coming forward through the retina and is at risk of bleeding. But using this combination of the OCTA and the structural picture, you can get a much better idea of the risk that it may or may not bleed. There's another example of, this is a multicolor image now taken on the OCT camera from Heidelberg. So it's not true color, it's a multicolor image. And you can see these various vascular things that look like IRMA, these intraretinal micro, or they could be new vessels. So that's the question. Are they, what's the risk of these? Do we need to treat them? When we look at the fluorescein, well, they do leak. So by definition, then they would be new vessels. When we look at the OCTA, they're interretinal. These are not, they have not come forward through the internal limiting membrane. So they're not quite, they look like they're IRMA, but they are new vessels because they leak. And you can see this network here. They're not coming through the retina, so I don't probably need to treat it, but I do need to keep a close watch. And that's the beauty, another beauty of the OCTA is you can keep a close watch, because you're not going to want to keep repeating a fluorescein probably, but you could repeat an OCTA. So actually we repeated this same spot after 3 months. And the interesting thing is it's grown in 3 months. So if you look at this little area here, that's larger there. If you look over here, this is all new. That's changing. It's still interretinal, but it's growing quite quickly. So we certainly have to keep a close watch, or maybe we need to be intervening before it breaks through and is a higher risk. And then if I am going to intervene, well, what am I going to do? Am I going to laser them, or am I actually going to do injections? And that's the other debate. What is the best way of treating new vessels these days? Should we be lasering them all, or should we be injecting? I'm not sure we fully know the answer to that, but certainly with this sort of technology, we can monitor what's going on more closely. This is a, hang on, yeah, okay. This is a patient who's recently had a vitreous hemorrhage. Oh yes, looking at the disc, there's a little bit of a vessel on here, it looks very small. But you can see why they bled. The new vessels are actually attached to the posterior hyaloid, they're lifting up, so that's why they bled. But otherwise, if you just looked at the color picture and seen that tiny little vessel, you might not have thought there was really a problem there. One more case on OCTA in diabetics. This is fluorescein, showing you a little vascular abnormality right on the edge of the foveolar vascular zone. this is the OCTA, actually showing you there's new vessels right on the edge of the foveolar vascular zone there, which are coming forward. So we didn't normally expect to see new vessels at the edge of the FAS, but they do seem to exist. But the interesting thing is this picture was taken in 2006, and this is taken in 2017. And if you look closely at this area, it really hasn't changed much at all. So that's reassuring. So they have got new vessels on the edge of their FAS. It's 11 years later and nothing's happened. So I don't know what to make of that, but it's an interesting finding. So my conclusion on the OCTA part is that I think it's difficult to predict your vision based on just looking at the FAS, for example. I think the OCTA does show new vessels very well, but it's showing us different things about whether these vessels are interretinal or in front of the retina, and you definitely need to look at the cross sections, the structural OCT in addition to the OCTA to decide your risk. And the relation to the fluorescein leak is actually rather variable. So I think what's going to happen in the future is we'll get wider and wider OCTAs. We will find a lot more vascular abnormalities than we thought were there in the first place, and then we'll have to worry about what we do about it. But we will be able to monitor it much better. I'm just going to end with a few pictures of a new camera, which is still being developed, but it is now available, which is the Monaco from Optos. So this is basically combining wide field color and OCT. So this is a wide field color. Sorry. And the wide field OCT taken through the middle of that picture, showing you the macular edema and also the disc. So that it's one camera, basically, which will do both. So when space is an issue and time and all sorts of things, it is potentially very useful because it's very useful to have both, the wide picture and the wide OCT. Another example of pretty gross disc-new vessels here, a lot of ischemia going out into the periphery. I mean, I'm a great believer in wide field imaging just generally, but certainly for diabetics it's brilliant because you can see so much more of what's going on and you can document it. But this machine will also give you the wide scan. So in this case, there's a large disc-new vessels here, but what we want to know is the traction on the fovea? Are those vessels actually pulling up the macula, or is it just edema? It's probably just edema, but there may be an element of traction here. And how are we going to treat such a patient? Well, we may well do anti-VEGF for this rather than laser straight away. You probably do laser later on, but if we do laser straight away, we're probably going to make the macular edema worse. So I would give them an anti-VEGF first and then consider laser later. Another example of even worse disc-new vessels in somebody who's already had laser. When we do our OCT through the center, we can see there is some traction, although it isn't really pulling the macula up very much. And you can get, obviously, several cuts going through. So it's just an interesting new bit of kit, but it's still in the, well, there's going to be different versions of it, but this one does exist. So in conclusion, OCTA is clearly personally, this is the mainstay of imaging for diabetic, and certainly for diabetic macular edema, but it is pretty useful combining that with wide field imaging, both fluorescein and color. The OCTA, I think, is to some extent of interest, and not entirely sure how much it's changing our management as yet. But we are able to monitor in much more detail how the circulation has been affected, and will certainly be useful for follow-up. And this further imaging probably will influence whether we're going to laser or anti-VEGF or what combination is best. So thank you.
James, thank you very much. It was really, really amazing. Yeah, well done.
Well done. No, actually, let's discuss a few things because it was very simulating talk, and
okay,
there's a lot to discuss. Are there any questions from the audience first? Please.
Yeah.
Thank you. That was really interesting. The patient that you showed that had the new vessels on the edge of the foveolovascular zone,
yeah,
that hadn't changed, but we don't know, they may have been protruding more. Did you treat them?
Well, I think they were treated PRP at the beginning because they had new vessels elsewhere, but we haven't treated them for the last 10 years. So that was, the first picture was 2006. Yeah. I think they did have some laser at that point, but then now we're 11 years later.
So you haven't retreated?
No, I haven't retreated those new vessels. And they are elevated, so you do worry, are they suddenly going to get a macular hemorrhage? But I guess I've never seen a hemorrhage from, well, hardly ever seen new vessels at the new vessels at the edge of the FAS. I didn't know that existed, because you're always told they just come off the arcades. But clearly they do exist. But the other thing is whether it's attached to the vitreous, I suppose, would tell you whether there's a higher risk. And if you notice, but on that scan, they're not attached to the vitreous. So they are forward of the retina, but there's no vitreous there. So the posterior hyaloid, you know, I think the patient's had a PVD. You know, the vitreous isn't there, so I guess the risk of bleeding is much less. So no, for the moment, we're just watching.
Amazing talk, thank you. From a vitreoretinal perspective, one thing we always worry about when we're giving anti-VEGFs is the potential effect of traction and how it might make traction worse. Have you had any experience of looking at those wonderful neovascularization complexes that you have coming off the surface before and after injections? At any point, have you noticed any change in those, or is that something you haven't?
Well, we haven't got a lot of follow-up yet with our OCTA of new vessels, but certainly you can certainly see change. You know, some of the new vessels. Well, we were involved in the Clarity study, which was giving aflibercept for new vessels, and they will clinically they completely disappear. You know, if you've got new vessels or new vessels elsewhere, you know, in laser if you do a really good laser, the new vessels will disappear in some cases, or at least they become stable. With anti-VEGF, certainly if they are proper new vessels as opposed to sort of partly fibrosed, they completely disappear. I've got examples where you've got quite large new vessels, you do the injection, you can't see them at all. Whether if you repeated the OCTA, you'd see a sort of ghost of a new vessel, I don't know, because they do reopen. So when I say disappear, you can't see them. So maybe there's no blood in them. I'm not sure they've entirely gone, because 4 months later they will often recur. And I think that's one of the issues of giving anti-VEGF for new vessels, is how often you're going to have to keep injecting them. You're certainly going to have to keep following them up. The DRCR.net have got a 5-year follow-up of Lucentis for new vessels, and they are still injecting. I think less as the time's gone by, but they have still required to inject. The aflibercept, we thought, lasted about every 4 months. In terms of whether it reduces the traction, or you can certainly induce fibrosis when you know, but you can do that. That also happens with laser. It just probably happens more dramatically with anti-VEGF. But I think often the scenario where I'm considering it is where there is macular edema and new vessels, because we know if we laser them, we might well make the macular edema worse. If we inject them, then hopefully we treat both. So it depends how advanced it is. If you've already got a load of traction and fibrosis, well, maybe it should be going to VR anyway. If it hasn't got a lot of traction, or there isn't any traction, then I think that's a good combination. Give them the anti-VEGF, then probably do some PRP. So that's what we would currently do, rather than just stick to anti-VEGF. But it is a changing field, because you know, some of these patients are young and they drive. They're worried about their driving license if you give them a lot of laser, so they don't want any laser. So they have an injection, they can see the vessels are gone. So some of them will stay having injections rather than actually having any laser at all. What we'd like to know is if we did keep doing that, does it burn out and we don't have to keep injecting? So I don't know the answer to that.
But Louisa, I don't know, James, whether you agree. I feel that the amount of traction you have post-injecting anti-VEGF is very much related to the amount of fibrosis you do have. Yeah, pre-existing one. And because we have all this concern when we inject pre-operatively before the lamps. And, our practice is we inject only within 3 to 5 days beforehand in order to avoid tears. But if there is no fibrosis at all, we rarely see at least significant amount of traction. I don't know if this is your...
No, I agree. I think clinically we don't. I mean, one personal observation I've had is that I've seen more aggressive fibrosis with aflibercept than I have with Lucentis, and quite aggressive, particularly if you use it per-operatively. And I think a few people have described that. So I think the type of anti-VEGF you give is quite important for that.
That's interesting.
But yeah, it's interesting. I was just wondering, sort of on a microscopic level, do we see traction? Can we see traction that we don't actually see clinically when we're using these more?
Yeah, I'm not sure. So certainly you can see OCTA. You can see changing in the pattern. You know, they describe. You can see a sort of that first picture I showed you was quite a lot of vessels of the new, but when you treat them, they will shrink to a so-called dead tree. There's much less active-looking vessels, but then they reopen again. The traction part of it is probably I need to look at more carefully.
Louisa, we had a tractional retinal detachment following Avastin use, and my VR colleagues in Leicester were very much against using initially. So when we became part of the Clarity trial, I fostered a bit of confidence in them. But exactly the same thing, James. We've seen that those patients coming back for more injections because obviously the new blood vessels coming up within a few months. That was our experience as well.
Yeah. You need to keep repeating the injection, but both the Clarity and the DRC.net study showed they got, in the Clarity one was comparing injections to PRP, and the interesting thing about that was these were patients with no macular edema at baseline, and the primary outcome of the Clarity study was visual acuity. And you would have thought if they have no macular edema, how can you expect to show a difference with visual acuity when the visual acuity is normal? But actually, the injection arm got better. They were statistically significantly better visual acuity at the end of 1 year compared to laser, despite the fact neither arm had macular edema and had normal vision to start with. So, there is a move towards injecting. But despite the risks, so it's always a balance.
Yeah, I mean, it's also very interesting looking at the cost utility of that as well, because there's been some interesting work now coming out which says, well, okay, that's great, but got the cost, the long-term cost of this to the health service is quite high, and that might bring more work for us as VR surgeons, because now people say, well, maybe a vitrectomy is the way forward for neovascularization. So it'll be interesting to see how that debate starts.
Yeah. Mm-hmm. But the interesting thing is in the protocol S, after 5 years, both injections or laser, they ended up with the same kind of vision. But obviously Neil Bressel says that it depends on what you want to find in a trial, to be honest, And we know even from the Crystal and Bridal trials that laser wasn't given a good chance to survive the trial. So it depends on how you design a trial and what you want to prove. But obviously, visual field is better, when you do injections. You have to consider the age of the patient and whether this patient is driving for another few years or having a much better quality of life for some time.
And also if they're female and of childbearing age. If you have a female type 1 diabetic being controlled on anti-VEGF injections who then wants to start a family, that's going to raise a whole load of new questions as to how you then control that. Yeah.
Well, I have some objections regarding the quality of life, actually, that you might improve by doing injections, because those are diabetic patients. They have multiple diseases. I mean, data show that an average type 1 diabetic may attend 50 medical appointments within 6 months. So essentially, by injecting for PDR, you actually multiply this requirement, and this will end up to
So I'm not trying to say injections are the best thing. I think it's a balance, but what I am saying is that you can stratify your risk more by the more detailed imaging you do. The decision of how you manage that information is another matter.
James, may I ask you one more thing?
Yeah.
You mentioned about assessing ischemia with OCTA.
Yeah.
In your daily practice, apparently it's much easier when we have access to OCTA to perform that and assess the ischemia. However, because OCTA is based on blood flow, and slow flow doesn't necessarily mean capillary dropout. So essentially, do you feel that OCTA may actually overestimate the diameter of the phase? And when you see ischemia on OCTA, would you be tempted to carry out proper fluorescein angiography? Do you find that there is difference, or do you find it's more accurate, the fluorescein angiography?
Well, at the moment, the field of view for the OCTA is quite small, certainly on the Heidelberg. So, if I'm doing a macular OCTA, I'm only going to see a small area.
To that,
so I don't know if the flow is an issue, really. I mean, it is said if the flow is really slow, it won't detect it, because the image is entirely made up of detecting moving blood, so it's theoretically possible that there is blood flow, it's just too slow to pick up. But I'm not sure how real a risk that is.
But high flow or super high flow
Super
or
flow,
super slow flow shouldn't be picked
This
up.
is true, it may miss it, but I think if your main concern is to get an accurate picture of what the phase is like, you're much more likely to get that with your OCTA than your fluorescein. I guess it depends how good your photographers are and how good the patient is and what the media is like, but you need a really early shot on your fluorescein to get a good picture of the phase, and quite often we don't get that. Just for one reason or another. You give the fluorescein, the patient feels a bit ill, so they don't get the first couple of shots and you missed it, or whatever, it's a bit out of focus. So for a reliable measure of, I think it's more likely to be reliable on the OCTA than it is on the fluorescein. Whether it's telling you entirely the same thing, maybe not. It's certainly much more repeatable, because you don't want to keep doing a fluorescein. Yeah. But I guess if I'm really worried about overall ischemia, the fluorescein would still be more useful, because you can, particularly on the Ophthalmica, because you see the whole retina, and that's maybe important to know. But I think that will change as we get wider field OCTAs. Mm-hmm. What OCTA doesn't give you is leak. Yeah, it is a static picture. You can't really distinguish artery from vein, because you need to compare it to something to be able to work out which is the artery and vein, because it's just showing you the flow in the vessels. It doesn't tell you whether it's fast flow or slow flow. Not on this system, anyway. So you see something, but not everything. So reality for nearly all these technologies, including the OCT, as you're probably sure, you need a sort of multimodal approach. You don't really want to do one and nothing else, because you need the other one to correlate what it means.
Mm-hmm. One more thing that I found very interesting, actually, very useful, assessing intraretinal IRMA, actually, from NV, and assessing the location of this suspicious NV. Yeah. When I was a resident, I was taught that, MV originates from veins. IRMA originates usually from arteries. I mean, do you think this is true? And this is another way, actually, of differentiating IRMA from NV?
I'm not entirely sure it's always the case.
Yeah, well,
I agree with you. I think,
but usually.
I think that is probably true usually, yes. Yeah. But one or two of these OCTAs, when we're looking at it, part of the trouble is you can't be absolutely sure that it is artery or vein when you're looking at the OCTA. Yeah, that's true. But the first example I showed, actually, it looks like it's coming off the artery and it's a new vessel. So, but I think you're looking at an en-face image, and maybe there's connections going down. I think to actually segment it really accurately and be very sure where it started is actually not as straightforward as it looks.
Well, it's funny, because now with OCTA we discover more and more things. I had a case last month, actually, with definite leakage on FFA. That was after ischemic branch retinal vein occlusion. And there were new vessels that they were leaking, and definitely they were originating from artery. So,
so there you go. I think there are both. I think actually, I've just come from the Heidelberg meeting in Bonn yesterday, and what we're seeing on the OCTA is an oversimplification, in fact, because the machines are trying to present you with a picture. So you're seeing the superficial venous plexus and the deep venous plexus. I didn't comment about it. Maybe that will come on in the later talk about projection artifact. So if you're not careful, when you're looking at the deep, you're actually seeing deep vessels, but you're also seeing a projected vision of the superficial onto the deep. So some of the cameras are getting better at getting rid of the projection artifact, but you have to be careful if you get rid of the projection artifact, because it might not be a projection, it might be real. But there's another system is to actually do you can scan cross-sectionally and rather non-fast and detect vessels. And if you do that, actually there is a superficial, an intermediate, and a deep vascular complex. And if you go around nearer the optic nerve, and in some other parts of the retina, there is a fourth layer. So you've got superficial and intermediate and deep, and there's a radial layer. It's not just two layers. And also, of course, they're not separate. They're not totally independent. There are vertical vessels connecting these. And so actually it's rather more complicated than you might think. So interpreting which connects to what and how there's still, it'll change what we see and how the algorithms of the different machines. All the different machines are different. So if you did to repeat OCTA on a different camera, you'll see something slightly different. And it's to do with a protocol that they measure flow with, what the scan resolution is, vessels will look smaller and larger depending on which machine you use. Yeah. So it's a rapidly developing field.
Thank you very much. I think we overran a bit. It was very stimulating. I think we will close this session for the break, and we'll be back in about 20-25 minutes.